to go ahead and turn it over to our speaker today, Emily Lambert. She's Director of Music Therapy here at WVU, and I'm going to let her introduce herself and then start her presentation. So thank you, Emily, and welcome to everybody who's here today.
Thank you so much for having me. This is a much bigger audience than I expected, so I'm really excited about that. So I'm Emily Lambert. I am the director of the undergraduate education program here at WVU. And prior to working here, I have been clinical work. Youngest clients, I'll talk about it a little bit later. My youngest client that I've served is about 18. The oldest is about 103. I currently just work when I supervise students. I provide services as I supervise students as part of our educational program, and I'm not doing any practicing on the side because teaching classes and keeping a program together is a lot of work. I have my undergraduate actually in music engineering, and then I went on and got my equivalency in music therapy. I then received my master's from the University of Miami, and PhD is in process from the University of Miami as well. This is my second school year here at WVU, hopefully sort of keeping things on track. It's been a lot of turnover in the first 6 or 7 years we've had the program here. So I'm looking forward to keeping things upright and moving forward and diversifying and whatnot. So I've been asked today to talk to you about music therapy and how it intersects with social work and things like that. I am going to temporarily stop my share so I can see all of your lovely faces. Lots of you don't have cameras on. That's fair too. My question for you all is, how familiar are you with music therapy? Like a 1 being, I've heard the term, never really dealt with it, and 5 is, I work alongside a music therapist or my sibling is a music therapist. How comfortable are we? Can we show me with hands, or unmute yourself or drop it in the chat, just kind of what our familiarity level is? That would be really helpful for me. So 1s, 5s. Let's give them participants. I don't want participants, I want chat. All right. Not getting a lot of feedback. So I'm going to go with I'm going to start at the basics and we'll see. All right, here's some chats are finally coming in. There we go. All right, so lots of 2s, 3s. Okay. So you know we exist, but haven't had a lot of experience with what we do. Excellent. Thank you for sharing that. Let me go back to... Oh, no. Hold on one more time. Gotta add that share sound. All right, perfect. So the first thing we have to do is define or tell you what music therapy actually is. There were some 1s and a lot of 2s in those responses for where your comfort level or your knowledge level was with music therapy. I have put the first definition on here from the American Music Therapy Association for you to have for reference in the slides that'll be sent out after this. It's very long. Mine is equally as long, but I think it's a little more digestible. Music therapy is the clinical and evidence-based use of music interventions to accomplish individualized goals within a therapeutic relationship by a credentialed professional who has completed an approved music therapy program. Music therapy interventions can address a variety of healthcare and educational goals, and then it goes on to list. That's quite a mouthful. So I am going to break it down a little bit. I ask students to start defining music therapy in our Introduction to Music Therapy class, and they work on it. And our junior year, we work on refining it and having it available for different audiences. So this is sort of my technical definition of music therapy, and I'm going to break it down just a little bit. So the first thing that I say is music therapy is a clinical process. So it's a clinical process because it does involve a professional relationship, a clinician. It is providing specific services for specific needs. We are an allied healthcare profession, so that is where that clinical process piece comes in. And it says we're in a credentialed music therapist assist the clients. Only people in the United States, I should qualify. In the United States, only individuals who hold a specific credential can actually practice music therapy. There's a difference between music therapy and using music therapeutically. and we'll talk about that in this presentation as well. But you have to have the credential, which is MTBC, to practice music therapy. And then we assist our clients in maximizing their functioning or their quality of life. So even though we are using music as the means of making things happen, we are looking to help them improve functioning, which is usually outside of music therapy. So working on social, communication, emotional, physical, cognitive skills, things that help them function in their everyday life, and or quality of life, because there are some things that maybe we don't want to quantify that are still really important to individuals. Having a happy memory with a family member before they pass is not really measured by a functional measure, but it is still something that is very important to individuals for their well-being or their quality of life. So we look at these ways of helping individuals across the board with a variety of skills, and we use various facets of music in therapeutic experiences. So we'll talk about all that more in detail later a little bit, but really we're looking at how can we structure music or a musical experience to help them get to those increases in functioning or increases in quality of life. And we're using music as the vehicle to get there. So sometimes the musical process is really important, and other times it's more of a jumping off point. But we're using music as that way, and the structure of the music or the way we engage others with music to actually improve the functioning or quality of life. And we're looking for that positive change. And the last element of my definition is it's based on a body of research, theory, and clinical practice. So we are evidence-based practice. Those are kind of the components of that. We look at research, peer-reviewed research, published research. We look to all of those things and try to increase that base all the time to show not only that things work, but also then to explain how or why things work. And then theories, there are many things that we can't measure and are based on theories because we can't fully understand how our brain or our neurological system works. We don't have the understanding at such a deep level that we're able to clearly explain how everything works. So oftentimes there's theory involved based on knowledge that we've gathered, and then clinical practice, the expertise that we gain practicing, and also the expertise that is shared by other individuals help us really create the best model for evidence-based practice for our clients. So that is quite a bit of information just in the definition. Whoa, I am so sorry. That is not what I meant to scroll. Come back with me. Oh, it is not a Monday, but it feels like a Monday, my friends. All right. So we are going to break down everything we just talked about. The first thing that I talked about was really working, being a credentialed music therapist. I want to give you a brief background on the education of music therapists. Later, we're going to compare it to other people who maybe use music in a different therapeutic manner, but don't have the same title as music therapist. So to become a music therapist, we have to complete an undergraduate program in music therapy, or there is an option, which is how I came to music therapy. I had my undergraduate in a different field of music, and I went and did the equivalency program, which basically meant I had to make up all of the classes that I had not taken in my previous degree. I didn't get a second bachelor's, but I completed all of those programs, or all of those courses, to make me eligible to become a music therapist. And some of those courses we look at are music courses such as history, theory, performance, psychology of music. Those are courses that I took during my other degree, my other undergraduate degree, and those are things that were also part of a music therapy degree. So I did not have to repeat those courses, but everybody who's going to become a music therapist has to have a solid basis in those areas of music. Additionally, we have to have, I'm going to jump down a bullet point here, we have to have a complete basic understanding of human systems. How do we work physically? How do we work psychologically? How do we work together? What is the diversity and cultural awareness? Things like anthropology, biology, anatomy. All of those things are things that we have to have a basic level of background knowledge on because we are working on goals in those areas and we need to understand those basics and how things work. And then on top of that, we have our music therapy specific curriculum. We need to understand the different philosophies of music therapy, all of the different techniques that people use, and we have to be able to apply them. So we have to understand why or where different things came from, the details and how they happen and how they work, and then actually get practice in applying them. And the practice in applying them comes both in clinical work, or I should say, role-playing work in classroom settings, and then also clinical work. A person who completes a traditional undergraduate program will get about 180 hours during their time in their classroom and during their clinical or their practicum work, where they get that time for planning, actually providing treatment sessions, and then doing the documentation afterwards. Here at WVU, that is once a week for an hour over 6 semesters. And so you get 6 different placements, and you go and see a group or an individual client once a week for 12 to 14 weeks, depending on when we actually are able to start, and holidays and things like that. So after you complete that educational program, whether it's the bachelor's or you went back and filled in the gaps in your education, you then complete an internship. Internships are designed to get you to a total of 1,200 hours of clinical experience. So after taking your 4 years of courses at most universities, you then do a 6-month full-time internship or the equivalent. Usually this is in one location, but sometimes they are split between 2 parts in a hospital or 2 aligned businesses, so individuals get different chances to work with different people. So you have to have that total of 1,200 hours working with individuals before you can then sit for your national board certification exam. And that leads to the MTBC credential, the Music Therapist Board Certified Credential. We have a 5-year recertification cycle that requires continuing education credits, just like you all are here for today. And that is something that you have to keep up over the course of your entire career as a music therapist to keep that credential. I just went through all of that really fast. Does anybody have a question they want to drop in the chat, or unmute themselves and ask a question? I see one right now. Do the internships tend to be paid or unpaid? Sadly, a majority of ours are unpaid, or they are a stipend, which is much lower than even minimum wage. This is a problem in our industry. The issue is that because our formalization of our profession in the United States really didn't start until the 1950s, and because for so long medicine and education were highly focused on very specific outcomes as opposed to treating the entire individual, getting reimbursement and finding jobs for us has been traditionally more difficult. So to then get money to pay interns on top of that has been difficult. It is a huge barrier to access in our profession and a huge problem, and that is a very long-winded way of saying they're usually unpaid or they have lower stipends. Are you placed into an internship, or do you have to find your own? You have to find your own in our career. There are 2 different ways you can do that. There are people that have gone through and have their internship sites approved by our national organization, and anybody can apply to those. And then we also have university-affiliated internships, where if a student is interested in a site, and that site provides internships, we work with that site to set up everything so the students are able to do that. Prior to my arrival, students only really completed national roster internships. Last May, I went through a whole process of putting everything together to make things more accessible to students. So we have 6 students now out of the 10 seniors we had last year so far who were able to complete university-affiliated internships, which allowed them to live at home and make things much more affordable for them. So it's bad that we don't place them, but it's good because we have students go all the way across the country and pick whatever population they really want to work with. So it opens up a lot of doors to finding where your niche is or exploring where you may want your career to go. But it's difficult because we don't place you and you don't stay at your university housing while you're doing it. Is there insurance coverage? Is there insurance coverage for clients, or is there insurance coverage for the students in internship? Clients. So clients actually. So depending on the state, usually health insurance is not significant coverage for music therapy. However, there are lots of states that have Medicare and Medicaid waivers that support music therapy or have other programs. I spent many years in Florida. Every 2 years, they change the name of the program, but basically, children who receive services through IEPs or other services through the state can get scholarships or money that they can apply to services that they feel are going to be helpful, and music therapy is one of those. Indiana has an amazing Medicare or Medicaid waiver that covers music therapy. And so there are a lot of music therapy services in Indiana for individuals across the lifespan that qualify for that waiver. So it really depends on the state and the particular company. Some people have had success billing medical insurance in certain states, but usually if it's provided in like a hospital or a medical setting, it's either grant funded or it's something that the medical system understands is really important and finds the money for. So that is something that our advocacy and everything that we're working towards is finding places to get more money for reimbursement and for insurance. These are excellent questions that I didn't even plan on covering. All right, you're welcome. I don't see anything else pop up. Oh, the chat is right there so you can all see. I'm special like that. All right. So we're going to talk about treatment process really briefly. I'm sure you are all familiar with a treatment process in general. And this looks very similar to most other professional, medical, educational systems, right? Somebody comes to us, we need that referral, then we assess what their needs are, we provide treatment, and we see if it works. We all use the RATE acronym in some form or another. When we're looking at this, there are a few different things that are important for music therapy specifically. So the source for referral, depending on the setting, depends on where you can get referrals. But in a majority of settings, people can self-refer for music therapy. In a medical setting, or people, if you have a private practice, people can just show up and say, I want services. So there's a little bit more access to that versus other services that may require a medical referral. So referral sources come from a variety of places in the hospital. It comes from a children's hospital, it comes from Child Life, or all hospitals. It might come from nursing or doctors or chaplains, or like I said, family or client referrals themselves. And the reason for referral, anything that a music therapist could realistically help the client work on is a reason for a referral. And sometimes it can be as vague as they were crying when I walked past the room in hospital. Or it could be this client is really struggling to integrate with their peers in the classroom and we want to work on that. Down to specifically, this client is having difficulty regaining articulation in speech after their stroke. So the reason for referral can be very wide and very narrow, and it can come from a variety of sources. So we do have a little bit more flexibility in most settings for our referrals. It's not like we require an ICD-10 code plus a doctor's referral to actually be able to assess and see if they're going to be potentially helped by services. And when we assess musically and non-musically. So we will use the same assessment tools that you all might in social work: chart review, interviews, asking the clients, asking their families, asking staff, observing them, doing some of the more standardized cognitive tests, like we don't usually do the mini mental state exam, but things like that, or the trail making test, 9-hole peg test. All of those standard things are things that if it doesn't require extra specific training, we use those standardized non-musical assessments. But we also assess in music. I don't know if you remember seeing our friend Henry on something from Alive Inside about 8 years ago that came out of the Sundance Festival, and it was an older gentleman in a nursing home, and they put on an iPod and put headphones on him, and he started talking. And before when they were filming him, he was just sitting there, not engaging with anyone, staring at the wall, and they put the headphones on him, and all of a sudden he started talking and sharing memories. There are many problems with that particular video in that clip. Things like giving a person headphones and an iPod that doesn't know how to take the headphones off or request different songs or turn down the music loudness, those are kind of problematic. But it's a good example of how people can behave very differently in a musical setting. Um, there are times where you might note that perhaps a child with autism or an older adult don't really speak much or open up. But when you play music, they might start smiling or speaking or singing along. We see lots of things happen in a musical context that we don't see outside of a musical context. Just this morning, we were at a practicum site and there was a new member of the group. It was their first day in this school classroom, like very first day. And they really didn't engage with anybody. But when I started singing the hello song and they came over and stood in their spot and started dancing, like phones came out to take pictures because it was something they had not seen from this student. Maybe today was their second day, but they had not seen anything from this student. And so it was different types of reactions can happen in music. Usually that works in our favor, but there are times where somebody might be really comfortable in a setting and we bring in music and they shut down. And that means that music therapy is not appropriate for them. So it's really important to assess that, to see things that we might not see elsewhere, but also to really look at, is it appropriate for them? So after we decide that maybe treatment is appropriate and we come up with our goals and objectives, we look at our broad area of skills that we want to target, and then we outline our very specific target behaviors and sort of the criteria that we want to see. And the important thing about that is that we do collect data. Because we are an evidence-based practice, that means not only do we base what we do on research, it means that we base whether or not to continue treatment or how to modify treatment on the data we collect. And this data collection can be everything from how many times did the client cross the midline when they're moving their arms during an experience, all the way up to how long did they actually stay present in a group? Because for an individual that might be in a mental health crisis setting, just being around others and tolerating stimuli and engaging with others by just being present for 20 minutes might actually be something that is really important to leading them to the next step in engaging in their treatment or being able to interact with others. So really our data collection is, again, a wide variety based on what we do, but it's really important that we collect that data to see if things work. And we are always evaluating in the moment, is this working? How can I change the music? How can I change my cues? How can I change what I'm doing to get a better reaction to help them improve more? And then we also do periodic reviews. I worked at the longest place I have worked was at a neurologic rehabilitation center in Michigan. Most people had been in motor vehicle accidents, and at the time, car insurance laws in Michigan covered music therapy as part of the necessary treatment. So we would have periodic reviews as short as 2 weeks if the client was making a lot of changes, to as rare as once a year that we would do evaluations and reports on the progress that had been made. So everything that we do can be very highly tailored and is quite variable across the span, which is partly why we have that full undergraduate degree and that background in all of these physical systems and psychology, and we have so many different practicum experiences and so many hours, is because we are trained to, at least at a basic level, work from before people are born and moms and neonatal or prenatal care all the way up to end of life hospice and family after passing. So we have that huge range, and we can work on any domain and any skill that we might be that is within our scope of what we know and how to treat or how to help improve. So I'm going to talk about the treatment process just really basically, because the second half of this presentation is more important, and we're hitting about the halfway mark to give time for questions. We look at how music interacts with all of the different things that we have and are as humans to show how it works. So we look at how music interacts with our neurological systems. We look at how both music and non-musical things affect our sensory motor systems. I have a video here that I think we have time to share in just a moment, but there are lots of different ways that music can impact our motor system. If I start singing bum bum ba-dum bum 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 ba-dum bum ba-dum bum, how many of you kind of maybe started tapping your head or your beat or bobbing your head along, right? We naturally move to music that has a strong rhythm. We don't even think about it. We just do it. This is something that is universal. It can be enhanced by learning, but this is something that is innate in humans regardless of culture. And there are several different theories or ways that the music and that rhythm can interact with our motor systems or our sensory systems to help access and improve or change or make things or use the plasticity of our neurological system in our brain to make those changes. Psychologically, if you listen to what you find a very moving piece of music, the areas in your brain that are activated are the same areas that are activated when you are experiencing that emotion without music. If you're listening to, I don't know, I had an album a long time ago, it was the greatest heartbreak pieces in the world. And they were the really moving, sad love story things. The areas of your brain and your limbic system and your anterior cingulate cortex, all of those areas that involve processing emotions, were activated when listening to that music, and they're the same areas that are activated when there's no music and we're actually experiencing the heartbreak or the sadness. So there's a lot of overlap in how music activates our neurological system and how those things happen naturally. And then cognitive wise, really the way that we make memories, similar processes, the way we access memories are similar processes, but also music can cue a memory, is more likely to cue a memory than like words. If you have a piece of music, there's a good chance that you have a strong memory associated with it. Maybe it's the song that you and your friends played every time you drove around before a football game, or maybe it is the song that your mother or father sang to you when you were a child. So there's a lot of cognitive and memory associations with music, and music can enhance those connections and provide those cues. Looking at music and the neurological system here, I want to show you this video. There's a lot of text, so just hang out and read along, and then I'll discuss it afterwards. But this is looking at an individual who is receiving neurologic music therapy, and he has a stroke, and so he has severe impairments when walking. After his stroke, he had 3 weeks of traditional physical therapy to get him to his first point. So as you can see, he's walking, and he has his foot, pain, foot, pain, going pretty slowly down the hallway, right? Oh, here's another video. He's maybe moving one tile on the floor with every step. So we have this process called rhythmic auditory stimulation, and what it does is it causes when we process sound and it comes through our ears, it goes into 3 different pathways, but the first pathway that is processed in our brain goes in our ear and goes down into our brainstem, because we need to process sound quickly for the fight, flight, or freeze response. Evolutionarily wise, we need to be able to have a very quick motor response to a sound. And there are different theories, again, because we can't get in there and see how exactly it works, on how this happens. But an external rhythm can influence our motor systems, especially related to gait, because when we are startled and we need to survive, we need to be able to run, and we need to be able to coordinate our legs together. So the first thing they do is they just add, at a specific tempo, they add. So they're imitating his walking with music. I wish that section was longer. That's all they do. But they continue to work with him. He's walking faster. After like one 45-minute or hour-long session, They took away the music, and this is how he's looking. That's 1 hour compared to where he started because of how music interacts with our neurological system. So he started out about 1 step per second using a cane, and he ended up at 2 steps per second without a cane. Here he is at the beginning. Here he is at the end. Still need someone holding a gait belt, but that's a huge change in the walking that we see. I show that video because it is by far the quickest evidence of how music can interact with neurological systems. Usually it takes a lot longer and more work, but that is in 1 hour. And why physical therapists have not taken this technique from us and used it for their own, I don't understand, because it's so quick and it's so immediate. So that's really how music and neurological systems can interact. And that is a very simple, straightforward demonstration, and it happens on a lot deeper level. Then we look at music and human behaviors. There's a statement that I've heard many times, and it's not entirely accurate, but people have said the only 2 universal things amongst all cultures over time are music and beer, or music and alcohol. Almost every single culture has some form of music or rhythm in what they do, either involving in their social rituals or as part of individual bonding, and it really makes a sense of culture and cohesiveness. The first thing that especially mothers, but all parents do, is they oftentimes learn to soothe their babies through rhythmic rocking and through lullabies. It starts when we're born. There's that social component of calming, of bonding. Making music together or doing synchronized movements together has shown in many studies to improve feelings of social bonding, and it can actually reduce feelings of prejudice and increase openness to other individuals from other cultures, either by engaging in their music or by doing a generic music activity together. Somehow when we see ourselves doing stuff in rhythm with other people or making music with other people, it makes us feel connected to them. And there's not really a explanation on exactly why that happens, but it's well documented across cultures and in many different situations. I already mentioned how music emotionally has the same brain activation as non-emotional. Most of us have had emotion induced by music. We've heard something that is so beautiful, so we get a sense of awe, or music, even if it's paired with something in a movie, has made us cry, or music has made us get up and dance and be happy. So there's really that connection between music and emotion. Spiritually, most religions have a musical element to them. And then creativity. As humans, most of us have a drive to create, to leave our mark on the world, to enjoy beauty, to enjoy aesthetics, and to be able to create something. For some people, it's more logical and it's, I want to create a building and a structure, but for a lot of people, it's more of an artistic endeavor, and that crosses over into music. Okay, so we're going to talk about sessions in a moment, and how many rhymes of "You Are My Sunshine," "You Are My Sunshine" you sang to your child as an infant. That was my mother's and my song as well. She sang me "You Are My Sunshine" when I was a child, and there's a recording of me at about 2.5 on a cassette tape singing that, and singing it poorly, and not even sure how we're going to play it anymore because I think we have lost all of the cassette players that we've had in our house. I will come back to your question about music therapy look like once you've established treatment goals and how's it structured. The answer to that is it's just as variable as everything else that we do. There are 4 main experiences. So this starts to get a little bit into the meat of what we actually do in those sessions, which is a great question. We have 4 different musical experience categories. They've been labeled this. There are flexibility, there are gray areas. But the first way that we can use music is in a receptive experience. And in a receptive experience, we don't expect the client to engage in the music. They might interact with it, but this might look like music therapists providing the music to induce relaxation or to help a client with breathing exercises, Or maybe we provide the music and they're reading the lyrics to the music, and then we're going to talk about the lyrics later. So they aren't actively creating music, but music is being used to get towards that eventual functional or quality of life goal that we're working on. We do recreative music, which is where the music therapist and or the client or clients, because we do see individuals and groups, are making music with a very specific structure. The easiest way to think about this would be if we all sang along to a song that we knew really well, or I gave everybody small percussion, maracas, and tambourines, and we all played along while somebody sang. So the recreative is more of an active music making, and it's usually on a structure that already exists. Now, that structure can be familiar. We can all go out and start singing Don't Stop Believin' by Journey and really get into it, or it can be a song that somebody in the group created, but everybody else in the group is helping recreate it. We have improvisation. If you aren't familiar what music improvisation is, it's really the spontaneous making of music within a structure, and that structure can be very loose or it can be defined, but they're not reading music, they're not following something that has already been made, they're making it in the moment. And this can lead to ways to self-expression, self-esteem by trying something new or being successful, or coming down to just moving on to the next one, sort of making that creating music in there. So improvisation is a lot more open and spontaneous for them to make music. And then creative can be anything from writing a song to setting up, sort of composing a piece and telling each person in the group what to play, to sometimes we do art with music so they can visually express what they're thinking about when they're listening to music. So those are kind of the four categories. So everything from just listening to music to process it later, all the way up to creating music of their own, either in the moment or over time. And we do this by structuring the different musical elements. If I want somebody to be able to raise their arms all the way up and then down and then all the way out and back, something we oftentimes do with dementia, individuals with dementia and memory care units, to keep their movement up as they're sitting in their wheelchairs all day, I have to make sure that the speed that I'm asking to do them to do this is slow enough that they can do it, but it's fast enough to keep them engaged. Because if I'm just going to do it like really slow over and over again, I'm not going to stay engaged. So even something with just the speed that we share the music has to be selected very carefully. And this is one of the things that I think separates music therapists from other people who might use music, is that we very much intentionally choose and look at and understand how shaping each of these musical elements can come to a different outcome. I have a guitar here. I want you all to take your hands and drop them out to the side of your chair. We're gonna do this, we're gonna like this. I want you to take your hands, I want you to drop them to the side of your chair, and I want you to squeeze your fists together. And I want you to relax. And I want you to squeeze those fists together. And then I want you to relax them. When I play that first chord, I won't go into the music behind it, but it leaves you feeling kind of unresolved. If I just sat here and played that for a while, you're sitting here going, maybe you get the little shivers, or you're like, I don't like that, it just gives me anxiety, or it makes me want to move forward, because we want it to go here. We want to feel that sense of, that's one of the most simple structures for getting people to perhaps model movements, is by squeezing our hands is kind of that really tense feeling, and then we relax it with it. So music can be used to guide the movements or to reinforce those movements. When I add those and I tell you to squeeze and then relax, because the music is giving us that secondary sensation to relax, the release or the relaxing can feel even more effective than if we did it without the music. I should probably doing more of those little examples instead of talking. All right. Before I move on to this, pause for anybody to, we're going to continue getting to how kind of the session looks like overall. Any other questions you want to drop in the chat at this time, or unmute yourself and ask sort of how we use the music and the different types of experiences and the reasons why. And if you don't have any, I'm going to take a moment for water. Okay. All right. Hopefully you're still hanging with me. This is a lecture heavy and it is lunchtime. I gotcha. Very briefly, populations we serve. Like I said, we work with individuals and their mothers before they're born, all the way up to families after they have passed. Looking at a medical setting, one of the more common areas that you might see music therapist in the hospital, in an adult hospital especially, is the oncology unit. People who are in the hospital dealing with cancer have a lot of pain, a lot of anxiety. They're processing a lot of identity changes or loss, especially if it is a female cancer patient that has had a mastectomy or uterine cancer. There's kind of a loss of sense of identity and femininity for a lot of women going through that. If you aren't going to be able to have the future you want, there's a lot to process with that as well. And then the pain and the anxiety that go along with that as well. So that's a very common area to see music therapists in a hospital. And then also in children's hospitals, music therapists are very common for things like procedural support. Trying to get an IV into an 18-month-old or trying to have a 3-year-old sit still through a procedure is very hard, because those poor children don't understand what's happening and why. And so we really try to find ways to provide that procedural support to make it easier on the patients, to make it easier on the medical providers. Normalization, a child would normally be in school, not in the hospital. So how can we bring in those academic skills? How can we bring in the stimulation? How can we make it feel familiar and comfortable? How can we give them choices that they don't have otherwise? Because when they're at home, they might choose what they eat for dinner or what clothes they wear, or that they're going to watch TV, or they're going to run around outside, and most of those choices are eliminated in the hospital setting. We work with mental health across the ages in medical and non-medical setting. I'm realizing that I'm running out of time here, so we're just going to breeze through some of these. Educational and developmental settings, we work with pre-K through adults in the educational setting, usually children that have, or adolescents that have IEPs, and we work on academic skills. We work on social skills. We work on self-regulation. All of those things that happen during typical development, but maybe they need more support or they are delayed in achieving those milestones. And through vocational settings, we actually have 2 settings here in Morgantown that work on pre-vocational skills with both adolescents and adults. And we work on helping them work on memory, helping them work on problem solving, remembering chains of things, all those skills that they would need to do, they would need to have to complete some of the jobs that they're training for. Residential, another population that we serve at a high level is elder care, especially those with dementia or those in skilled nursing facilities, and helping them have an increased quality of life by providing meaningful interactions, activities, socialization, creation. If you all have worked or work in skilled nursing facilities or work with those individuals, you lose a lot going into those settings. And so we try to bring back as much of the joy, the happiness, keep up the physical skills that help them with activities of daily living. We try to do as much as we can in that setting. In the community, these are some of our underserved clients that are traditionally underserved, but we also underserve them because it's a matter of funding. Unhoused individuals, people in foster care, people that perhaps need educational outreach, especially in marginalized communities where they may not get or may not believe certain information, especially about medical diagnoses, and we're there to kind of create a better bridge to that so they can help take better care of themselves. And then if you own a private practice, you can choose whoever you see. So looking at music therapy, man, what am I going to drop out because I'm talking too much? So music therapy versus therapeutic music. I'm not going to have you go back to the slide, but to the grid where I can see everybody, but Do you use music to help motivate you to exercise or to pace your exercising? Do you sometimes have a bad day and you listen to a song that just makes you like feel that bad feeling even more? Or maybe you're having a bad day and you choose a song to really like pump you up and change your mood. We all use music with a purpose some ways in our lives. Maybe back in your college days, you had your playlist for when you pre-gamed before you went out on Saturday night to pump up with your friends and things like that, right? So we have that personal use where we can use music with a goal. And there are other professions that use music therapeutically. I can give you a link to share as well, maybe to Sarah or Mary, about these different people that use music in a therapeutic manner. Most of them are in hospital settings, either in hospice settings or bedside musicians in the hospital to bring meaningful experiences in pain reduction. The most training that I saw for any of these is about 150 to 200 hours total before they're able to do this. And then we have other professionals that can use music in different ways, and we're going to talk about how you might do that in just a moment. Nope, you're not going to forward on me. So I was going to have you sit and tell me some of your populations and the most common populations you work with, but I just had to make assumptions when I made this presentation. So we're looking at populations where families might have difficulties. I'm assuming that's something that many of you encounter frequently. And this can come from a diagnosis or diagnoses that individuals might have, trauma, conflict within the family or the inability to resolve that conflict, loss, inability to communicate. So some things that we look at might be to increase bonding. And to do that, we might just have a family group make music together. Because like I said, that making music together to a beat or synchronized movement to a beat can immediately increase feelings of affiliation and decrease feelings of outsider or resentment or those types of things. It's really important in a family dynamic for people to be able to express their thoughts and emotions in a safe space to each other or to the therapist. So we might engage in songwriting, but a common way we might do that is a song share. If an individual brings in a song and says, "This is how I'm feeling," it's less threatening to the other people in the group. If I come up to you and say, "You hurt me and I'm mad because you did this," versus if I share a song and say, "This songwriter seems to be saying that they are hurt when this happens," it's a less confrontational way to introduce a discussion, to share feelings. It's easier to share what might be happening with someone else than what's happening with yourself. It's less threatening. And it might be easier to hear that information when it's put in that externalized context. And we all listen to music. And so by saying that this artist has said this, it's a way to start broaching these topics or making it more comfortable to discuss these things. And then healthy conflict resolution. Playing music instruments and improvising and making up music on the spot very often can reflect how someone is feeling. If they have low energy, they're most likely not going to be playing away on their instrument. It's going to be reflected in their body language and the music that comes out when they play. If somebody consistently doesn't listen to other members of their family, and that is part of the issue at hand, we can actually have experiences where the music therapist asks each person to repeat what the person before them played and then change it, because they are forcing themselves to listen and acknowledge and repeat what the person before them said. It's harder to make people do that verbally. It's easier to do that within a music therapy or a musical setting. Generally, lots of things we ask clients to do are less threatening when we involve music, which is partly why it's successful as well. In looking at individuals at the end of life, we know the issues or the difficulties or the reasons why things at end of life can be difficult. Oftentimes, clients who are nearing the end of your life need to have self-expression. So maybe they're going to create songwriting or playlists. If you've had or thought of individuals writing letters to people to resolve the conflict at the end of their life, and maybe they send them and maybe they don't. Sometimes creating a playlist or writing a song is a different way to do that. Or maybe they want to do the legacy project and make that memory and leave something behind for their family that they have created specifically as a memory for them. So we can do that through songwriting or creating playlists, or legacy projects where maybe they'll share 4 songs and then they'll share specific memories about those songs for their loved ones to focus on. As someone is imminent, someone who's about to pass, can oftentimes be a very sad moment in the room. And you have these memories of sitting by bedside as somebody is passing away, and it's very difficult. Making music as a group that either engages the client or is around the client can really bring a positive memory to that time. Do you remember when we all sang Grandma's favorite song when we were there in the hospital room, and how we were crying, but we were also smiling, and it was that moment that we shared? And so it brings together the family. It creates those positive memories towards those last moments. And then in any setting, pain reduction, relaxation, breathing exercises. Lastly, substance use is another common population. We can help identify coping skills by looking at the lyrics of a song. Oftentimes, when individuals get the urge to use, or when they remove the people and the use from their life, they're not sure what to do with themselves. So we might teach them how to play guitar or ukulele, but we're not teaching them as you're learning music for music's sake. It's you are learning music as a leisure skill, as an alternative, as something that you can do. And then in all of these, sort of processing trauma that led to the use or trauma from the use involves music psychotherapy sessions, and music psychotherapy does require more experience, more training, and there's as many varieties of music therapy as there are in psychotherapy. So some of us draw on cognitive behavioral, some of us draw on psychodynamic. That's as variable as there are in therapy, and it depends on an individual's training, their philosophies, and all of those. So the most important slide for you all as we finish up: what can you do with music as a social worker? Because we don't own music as a means of getting people to improve their lives. We own the title, own, in quotations, music therapy, because like a physical therapist has certain duties versus a personal trainer or somebody who uses exercise as part of a plan in a psychotherapy approach. There's different levels. But just because you don't have the title music therapist, there are lots of things that you can do to help your clients using music.
Yeah.
And I said, as I mentioned in what we do, you can do the same thing, that we can use music as a jumping off point, as a talking point. If you have a theme that you think your client might want to discuss, you can choose a song and you can play the song. You don't have to play it. You can play a recording of the song and have them listen to the lyrics and have them start talking about the lyrics and what emerges from the lyrics and how they relate to the lyrics. It's a way for people to start talking about things by associating it to other people before they bring it to themselves, to opening up that conversation. If they're a music lover, if they really enjoy music, this is a great way to get them engaged in therapy as opposed to just talk to me. Similarly, you can bring in that lyric analysis for them. They can bring in song shares. You can learn a lot about a client by the lyrics of the songs they bring in to share, the tone of the music, the artists, and by having them explain why they brought in the song, why it's important, why they like it, really starts conversation, like I said, as a talking point and gives you insight to working with them. If you are working with individuals that perhaps need to have that increased sense of bonding, either with you or with other members of their group or their family, you can play that music together. You do not have to be an exceptional musician. You can go and get a few hand drums and you can pull out their favorite songs and you can just try out a few basic patterns to play along so you're all making music together. Or you can put together dance, because any type of rhythmic synchronized movement brings in those feelings of social bonding. Also works great for breaking up a session. If they're discussing things and they just kind of need a break. I don't know if you all take dance breaks during your day where you just put on music and you just rock out for like a few minutes, right? You can do that in sessions too as a way to break it up, to get them to release energy. If they're showing that they're really anxious and that they're having a hard time moving forward, you can take a break and you can dance at high energy, or you can use music. There are so many different apps and music out there where you can actually breathe to the music and it's cued within it. There are things that you can use within your sessions that are available to the general public. And then lastly is music for mood. Playlist creation, and the ISO principle. The ISO principle, yeah, I know you all have to leave. I'm working on it. The ISO principle is the idea of meeting a client where they are at and moving them where they need to be. If you're working with a client who is very angry or they're angered often and they need to find a way to calm, you can help them create a playlist that matches them at that energy level of angry, and then slowly bring stuff down on their playlist to an area where they are more calm. And so that's something that you look into. I think the ISO principle is very basic, but it's very easy to utilize with music. I talked for about 5 minutes longer than I anticipated. Thank you all for listening to me chat. Please continue to ask questions or unmute yourself, anything like that. I know this ends at 1, but I don't have anything immediate, so I can answer as long as you all have interest. Thank you for coming today.
Thank you, Emily, for presenting. That was really nice and interesting presentation. So if you have questions, if you want to, you can go ahead and type those in the chat. I just want to remind everyone to just, if you have a minute to complete our evaluation survey, I did put the link in the chat. But you will also get that with your CE certificate. So if you don't have time to do it now, you'll get it later. So. Well, if we don't have questions, I think we can wrap up because we are just about at time. But yeah. Thank you, Emily. I really appreciate you presenting for us. This was great.
Yeah, thanks for the invite.
Yeah, and you know, I hope to see the rest of you and Emily, you too, if you wish, at our future Lunch and Learn seminars. So thank you.
And also on the presentation is my email. If any questions come up, if you want more information, if you want me to come do an in-service with people, all those things, my contact information is on that last slide for you.
Perfect, thank you. And we will be sending out those slides to folks for those of you who joined us late. So.
Perfect. Thank you all. Take care.
Thank you.
Happy Valentine's Day.
Yes.